Endovascular coil embolization of unruptured posterior communicating artery aneurysm. The patient is a 60-year-old woman who presented to her primary care with a new onset of a headache. She was neurologically intact without cranial nerve deficit, but was found by CT angiography to have no subarachnoid hemorrhage, but a posterior communicating artery aneurysm on the right, measuring a centimeter by a centimeter. She was taken to our angiography suite, where right femoral artery access was obtained, and right internal carotid angiography confirmed the finding of a narrow-necked aneurysm that appeared amenable to endovascular coil embolization. Here you can see the aneurysm being catheterized under a roadmap technique where a microcatheter is advanced over a microwire. Once the aneurysm is catheterized, the microwire is removed and replaced with a framing coil. The framing coil is the first coil that we use in the aneurysm, and you can see that coil being placed here on AP and lateral roadmap angiography. This takes a complex shape to decrease the chance of the coil herniating out of the aneurysm, although the aneurysm again is relatively narrow-necked. As the framing coil is placed and fully within the aneurysm, the coil is detached after an angiographic run, which is seen here, confirms that the coil is well within the aneurysm and the parent vessel is widely patent without thrombus. The coil is detached, and now further filling coils are used to fill the aneurysm and assume the shape of the previously placed framing coil. Here you can see on AP and lateral views, using a reverse mask technique, that the new coil is dark, whereas the previously placed coils are in the background. This gives the opportunity to see any coil movement and the exact position of the newly placed coils. Once the last coil has been placed, an angiographic run is again performed, and this confirms that the aneurysm is no longer filling and that all of the parent vessels are patent without evidence for thrombus formation or any other complication. The patient was extubated and was taken to the neurological ICU, where she remained neurologically intact and was discharged to home on postoperative day number 1. The procedure was performed under general endotracheal anesthetic. EEG and SSEPs were monitored throughout the case. The devices that were used are seen on this slide, and the patient was not heparinized or placed on antiplatelets before, after, or during the procedure.